Good morning to everybody. It's a real honor to be here and to be invited by the mentors of everybody of us, because Salama Brothers, as we call them over in Italy, David Gabriel and many others were our mentors over in Europe. It's a great honor to be here and to share some of the thoughts and our philosophy with you. I get to acknowledge my guys at the university and my team in private practice. I am 3 days at the university, 2 days in private practice. I limited my profession to implant dentistry and to the surgical side right now, since we got on board Fabio Scutella, who is a US-trained prosthodontist SBU, and so mainly the work that you see here is done from the prosthetic point of view by Fabio Scutella. These are my disclosures. We are working with many of the companies that you see at the booth. And just to give you an outline of what we will present in today, we will go very quick through the literature, because to give you the background and our experience on the topic. So we started almost 20 years ago, because this was published in '98 and was a prospective multi-center study evaluating early loading. So at those time, almost 20 years ago, it was not so normal to load at 2 months, especially in the upper maxilla. So these are cases done 17 years ago with a good survival rate at 1 year. And then you see that the implant distribution is more or less throughout the arch, the upper arch and the lower arch. So pretty much all the different teeth, as you see here, are represented. And the failure rate, we saw that if you early load the implants, the preload failures and the postload failures, this is the failure mode in which mainly the preloading failure means that before the construction of the prosthesis, and that's from the clinical point of view, it's quite interesting. So if these implants were to fail, they were failing before the prosthesis and not afterwards, but this failure is more consistent with the rough surfaces compared to the old machine surfaces. Because with the old machine surfaces, we had a failure mode that was most equally post-loading and pre-loading failures. And then we went on, and another paper in 2002 with a lot of patients, partially edentulous patient, 164 patients, 405 osteotomy implants consecutively placed. And again, we had quite a few patients in this study. This is just chart from the study. And again, the life table analysis at 3 years post-loading, giving us a good survival rate of implants loaded 6 weeks, 8 weeks after placement. You see the distribution of the implants. In this case, in the posterior region, maxillary sides, mandibulary sides, and imagine that was 2002, 3 years post-loading, so were cases done during the 90s in which we were waiting for loading for at least 6 months. So it was a big reduction in the loading time. And mainly, as you see here, are short span fixed bridges, and you see few full arches and some single tooth replacement. So it seems to work well throughout the different type of reconstructions. And again, the failure mode is 60% of the failure were preloading failure, meaning that most of the failure before the construction of the prosthesis. So the conclusion of that paper was a significant reduction on the healing period compared to the 6 months suggested classical protocol. Then we ran some randomized multicentral controlled clinical trials, and we found no statistically significant difference between early and immediate loading. So we start comparing the two groups. So in this study, we had two groups, immediate loading and early loading. There is no significant difference between the two groups, even if you see the bar of immediate loading is a little bit lower compared to the bar of the early loaded groups. Now the bars are almost equal because our learning curve has increased. We are working and we learn over the years on how to achieve a better primary stability, and obviously these were cases done more than 10 years ago. And then another study comparing immediate non-occlusal loading versus occlusal loading, and we were very pleased to win the best article in JOMI in 2007 for these randomized controlled clinical trials, in which we showed that there were no major clinical differences between the two groups. And you might ask yourself, what about the bone levels? What about the soft tissue levels? So another randomized clinical trial in COIR, and no differences from the statistical point of view in peri-implant bone level and soft tissue changes. And this is at 5 years, the same set of patients at 5 years, same numbers even in 5 years. Now we are writing the 10 years. Again, the literature, to give you not only our literature, but this is a recent paper, a systematic review, the highest level of evidence. It seems that immediately loaded and conventional loaded single implants crown are equally successful, and the torque range is something between 20 and 45 Newton centimeters, and the ISQ is in the range that you can see there. The clinical range that we are using now on a constant basis, something around 40 to 60. That is the clinical range for us for immediate loading. If we splint more implants, we can lead even lower that kind of range. If we are in very dense bone, we are not really concerned about the torque, because we can even immediate load implants that are with 20 newtons of torque in dense bone. That means white bone on a CAT scan. So for us, as a clinician, the torque is correlated to the bone quality and to biology. Another paper that you see from Gallucci and co-workers, Schrott and co-workers, similar implant survival rates, and then always the phrase, as long as strict inclusion and exclusion criteria are followed. And we will see with our clinical cases what is our philosophy, which is our philosophy regarding this little quote. These are the included studies, and you should look at the included studies, but really there are the name of a good friend of mine, Jeff Ganelles from Boca Raton, our papers, and the conclusions are based on few studies. This is the limitation, because why only few studies? Because these are the studies that were included according to the inclusion criteria, very strict randomized clinical trials. So there are not too many randomized clinical studies in the literature. So it's a big difference between efficacy and effectiveness study. Are we talking about the real world, or are we speaking about efficacy study in selected the ways in which we follow a strict inclusion criteria? So if you are opening the gates and many patients are enrolled in this procedure, you won't be in this meta-analysis. So even if we are quoted, and it's an honor for us, I should be very frank to you, this because of the study design, and the number of patients treated here is not the number of patients that you would like to make your clinical decision on. And again, the survival rates of immediate loading, and the other one you can see in this forest plot, the one who favors the maxilla, the one who favors the mandible. It seems that the mandible works better compared to the maxilla. And again, these are the numbers, and these are the authors included in this meta-analysis. The Cochrane library, it's even more strict as an inclusion criteria for accepting papers in their meta-analysis. So we know that this is the highest level of evidence, but you as a clinician, myself as a clinician, we don't get that kind of information reading those papers. But it tells you that there is a learning curve embedded in the procedure, because it's possible to immediate load or early load in selected patient. And what does it mean? Not all the clinicians might be able to achieve the optimal result. Means that there is a learning curve embedded in the procedure. So the more cases you do, the more experience you get, the better the result usually are. And so in everybody of us, the skill of the operator, the skill of the surgical team, the prosthetic team plays a role. In the other one, in the very recent one, there is this quote, "No convincing evidence of clinically important difference between the two loading modes." If we gotta show some cases to show you our philosophy, in the posterior area, our philosophy, because our economy over in Europe is not so good as in the United States, we are not able to pump so many bucks into our economy. We are not able to print euros. And we, from the southern part of Italy, from the southern part of Europe, are even worse than the other part. So we try to modify our way to do implant dentistry to make it more affordable to the ordinary patient. We try to simplify the procedure. We try to minimize the invasiveness of our procedure. We try to touch the patient only once in order to reduce the fees, because our fees were reduced over the time, and so we increased the efficiency of the procedure. So if you see this case, there would be many options. We will show our option, keeping in mind there is only one diagnosis, various treatment plans, different ways to perform the chosen option. I'm not saying anything new was said by your masters, your clinicians, that your mentors over the years. Morton Amsterdam, I've been to Penn recently, last week, and this quote comes out in every meeting, because it's really, it's a matter of being very practical. It's true. And if we go back to this slide, there will be thousands of ways of doing the implant treatment. The one that we think it's very efficient, straightforward, is to take the teeth out. In our mind, post-extraction implant do not exist. Exists the right position of the implant. So placing the implant just in between the roots of the molar, it's a matter of having the right technique, the right handling of the handpiece. We teach the student to use both hands in order to be like a human pantograph, a human machine, and you can place the implants in the spot where you are. So we want to place the implants there. It's a matter of technique. And then we place the implant in the premolar sides more towards the buccal, because aiming to the buccal cusp, as you can see there, because our prosthodontists, they like that position, because the emergence profile is better if we place the implant a little bit a little bit towards the buccal cusp, not impinging, obviously, on the buccal wall. And then what we do, we graft on the buccal size, bovine bone usually, keeps the volume. We place a collagen sponge on the palatal side because we want to have a little bit of resorption. It's better for the future emergence profile. And we can do a little bit of soft tissue modification, as the Salama brothers and many others, Garber, taught us, to pump out a little bit the tissue, to make the tissue a little bit thicker. So again, different ways of having at the end an harmonious ridge. So in our mind, these are three healing caps, white, connected together, splinted, that they give you the ability to the patient to have a little bit of aesthetics. We tell them not to chew on this teeth. We are not aware that that's the case because we are running a study. Even if you are telling them not to chew on the newly placed immediate load prosthesis, after a week they start chewing the prosthesis. So non-occlusal loading, is that so important? When you read a paper, non-occlusal loading, are we pretty sure that they are not chewing on that? Most probably is related to the country, because I'm half Italian, half Swiss. If I'm running this study in the German part of Switzerland, you tell them for 8 weeks and 2 seconds, do not chew on this one, and they will check, okay, it's 8 weeks, 2 seconds, I can chew on this. If you say to an Italian, don't chew on this, they forget everything, and after 1 week, they chew on that, maybe after 6 hours. So it's really a matter of country-specific kind of immediate loading, non-immediate loading, and so the clinical recommendation is splint the prosthesis altogether, impression at least 3 months later, 2 months, it's up to you, non-occlusal loading with all the limitation that I said to you. Maybe I don't know here maybe in the Miami area, more like the Italy, in somewhere else in the United States, more like Switzerland. A lot of differences as well here. And this is the final restoration. Our clinical experience is mainly restricted to 2 3-unit prostheses, splinted together, single premolars, in between natural teeth, single molars without aesthetic implications. Patient does not show molar area or is not concerned for him. It's not a concern for him. We go delayed. So there gotta be a clinical indication. If there is, it's not a concern, not staying for 2 months without an immediate load prosthesis. We leave the patient for 2 months, no problem. I mean, you cannot maybe leave the patient without premolars, and so if we have the premolar region, we try to immediate load that because it's much more efficient. And all of a sudden, we got even a molar, we splint everything together. But if I get to do only a single molar, there is no clinical indication, no concern about the patient, I will leave that just early loaded. 2 months later, you will have your crown. Is it fine for you? More than 5, doctor, let's go like that. Again, cases in which the problem is not related to the implant. The problem is related to soft tissue modification, soft tissue management, to learn how to combine multiple procedures at the same time. So the loading mode now is not a concern for us. We learn over the years on how to achieve a predictable primary stability in normal bone, and the range I told you is between 40 and 60. We are using conical implants, tapered implants, because tapered implants it's easier to achieve primary stability with conical implants compared to cylindrical implants. The thread pitch plays a role. the thread design plays a role, the shape of the implants plays a role. So in all those cases, we mainly use nowadays conical implants, even if we have some cases in which we use cylindrical implants, but those cylindrical implants were very stable. I'm not meaning that you cannot achieve a sufficient primary stability with cylindrical implants. I'm meaning that it's easier if you use conical in our. This is a case in which we are going to extract premolars and molars, and again, some soft tissue modification at the same time, sliding flap from one side to the other, take a connective tissue graft. If you open the flap like this one, and the most efficient way is to take an impression, and the only approved material, FDA-approved material, to be used when you have an open flap is this material. It's coming in single packs, sterile, single use, and radio-opaque. We take an impression and we deliver the prosthesis the next day. Usually, it's much more efficient. So you do the surgical phase, 10 minutes you take the impression, you let the patient go home, and then next day you deliver the prosthesis. And this soft tissue modification, nothing new, but combining this soft tissue modification during your surgical procedure. That's the message for you as a clinicians. In this case, our dental technician worked very fast and provided us the final abutment. Okay, let's put the final abutment. It doesn't make any difference if we are placing screw retain and there will be another disconnection. Do we really believe that animal studies, I'm not quoting the animal studies, everybody of you knows the one abutment at a time, but if you have very thick tissue and you are in the posterior, it's not very important according to our clinical experience. So if we can to provide the abutment right and only disconnect the abutment only once, fine. If not, fine as well. So we cement the prosthesis. We did not find any difference between cemented and the screw retain. It's easier, it's cleaner, maybe it's less technique sensitive if you screw retain those prostheses, like the one I was showing in the previous case. So another important message, if you can avoid cement, it's better from the clinical point of view. And again, the final prosthesis. You see, only once the patient was operated from the surgical point of view. That's our philosophy. Can we do it? Can we pursue that goal? Most of the time, yes. And this is the patient. Now we try even to use all the ceramic prostheses because the economy is not so good. So if you can use the old ceramic prosthesis of the patient and let the patient get a little bit better from the financial point of view, it can keep those prostheses for a while and then go to the final. And this is one of the cases in which the failing lower left, before placing the implant, you should know how to extract in a traumatic way the roots. So we are dividing the roots using the piezoelectric device in order to preserve the buccal plate, to have all the content, the bony walls. And so we are just sectioning single-rooted teeth in different, and then you slide, you take out the lingual aspect, and then the palate, and then once you remove the lingual aspect, you push the root over to the lingual side, and you extract in a very traumatic way. On slides, it's only 30 seconds. Maybe in reality, it takes 20 minutes because it's not so easy. And then the implants goes in in 7 seconds. The big part is extracting the tooth in a traumatic way. On slides it's like that, but in reality it's not like that. And so, again, site preparation is very important. So we want to place the implants in the right position. In our mind, post-extraction does not exist. It's a matter of technique. And then, once we placed the implants, we can do a little soft tissue augmentation, little bone augmentation. If we do that, we use intermediate abutments because it's much more cleaner. When Fabio gets in, the prosthodontist gets into the OR, I have everything just closed, and we are going through an abutment that divides the surgical field from the prosthetic field. And then we use the ceramics of the patient. And you see, the other one was early loading. Why? Because it's much more difficult to get even the other one. The procedure will be longer. The patient will stay in the chair a little bit longer. It will cost you more. So we will leave that implant over there, and we will use later on. So a combination of immediate loading and early loading. In our philosophy, there gotta be a clinical implication. Why I'm immediately loading those implants? Can I leave those without loading? We know that it works. If we are going to do this, because there gotta be a clinical indication or a request from the patient. And then it's up to you to decide, can I do that? It's too risky or not? That's the second level of thought. Look at this case, and even the lower arch can be restored in different ways. And the treatment plans that crosses your minds can be various, very different. We pick up where the good bone is, and maybe we are extracting teeth, one teeth that can be saved if we have a patient who is very young, who is everything is completely sound teeth, only one tooth that has a problem. We strive to do everything to save that tooth. You will see at the end how old is the patient, 76. So being 76, she can be operated only once, is better for her. You reduce the cost, you reduce the invasiveness. That's why we are going to extract the cuspid in a 76 years old patient to make everything just more simple. As you see here, 3 implants, and you tell me, why are you extracting that cuspid? Because the analysis is not based only at a tooth level, but it's based even at the patient level. So patient level, tooth level, and it's short-sighted if you are extracting tooth only taking into consideration the tooth level. So with 3 implants, we took an impression in good bone, good primary stability. We can solve the problem operating the patient only once, as you can see here, and a 3-unit bridge. And this is the patient. Would have done the same treatment planning if she were 26, 24? No way. The level of analysis would have been different. That cuspid would have been there, and then we would like to regenerate and to do everything that we saw from the previous speakers. But at this age, it's a matter of ethical issue. This is our philosophy. We said that the personality of a tooth depends on the age of the patient, because it depends on the patient itself. So the patient dictates the treatment plan, and then to a second level, tooth level analysis. Again, can we be efficient if we are judging those quadrants completely hopeless? The last implant left to heal unloaded. Why? Because we can reduce everything. We can reduce the cost. The procedure will be quicker. And so, next day, we are delivering this screw retained prosthesis. We wait. We place the final abutments. We do some soft tissue modification with the prosthesis, with the provisional prosthesis, and this is only done by our prosthodontist, sculpturing the tissue with the prosthesis, and then the final restoration. This is another case in which we are combining post-extraction implants, implants in crestally lifted sinuses, splinted together, good primary stability. And I think that splinting an implant, like in this case, the last one, to a very stable implant does not, and you think, oh, it's a sinus lift. It's going to show something crazy. No. In our opinion, you are not jeopardizing that implant, but you are splinting that implant, or you leave that implant uncovered, or if you are putting a cover screw, it's more, I think it's more risky for that implant. And so again, an immediate load prosthesis in this case, and final case, on the other side, we remove the implant, we are using tilted implants, and we finalize the case. At that pink ceramic is not that great, but the patient does not show, he doesn't want to have any block graft, he doesn't want to have any kind of reconstruction, and so we compensate the bone deficiency with our ceramics. When we go to the aesthetic area, our thought process changes completely, because now the patient is coming for having aesthetics, not an osseointegrated implant. It's coming not for having immediate loading, but to have a long-term aesthetics. And this is one of our implant aesthetics core. Many others in the literature followed, mainly by the Austrians. And so you can divide in different levels, perfect outcome, almost impossible to achieve in clinical practice. If we stay in the acceptable outcome, we are more than happy. If it's a compromise outcome, 0 to 3, what the patient really thinks about that. This is our view. This is the patient view and the other clinician view. Usually the patient, the judgment of the clinician is typically more severe than the patient if we are in the acceptable range, because we have more parameters that we check. But what we found, and this is the patient view, if the objective score tells you compromise outcome and the patient complains, he has a reason or she has a reason to complain. If it's and does not mean that all the compromise outcome means that the patient will complain. Some of the compromise outcome for us, our clinician view, for the patient is more than satisfied. So That was just shocking for us. And so next time you deliver a crown with a big smile and tell to the patient that it's a good crown. Because if you are not satisfied, the patient can perceive that you are not satisfied, and all of a sudden he will see that crown in a different way. And always think that the more you have knowledge in dentistry, the more you have sophistication in dentistry, at the end, you don't like what you have done. And the next time, you say, if I'm doing this case the second time, it will be better. It's normal for us. It's not normal for the patient. And what about in the aesthetic zone? It seems from the more recent publication that immediate placement with immediate provalization get good results. We submitted a retrospective study in which we had more kind of recession when we were doing immediate loading, immediate provalization. And sometimes it's beneficial. If you start with square teeth to have a little bit of recession can be beneficial. But that kind of recession is not beneficial if you want to get the same level throughout the arch and you get to place only one tooth in between natural teeth, like in these cases. And these are cases done, immediate loading, immediate provalization, but all these cases are the ideal cases in which we have a thick tissue, in which we have all the parameters that allows you to be successful. Like in these cases done many years ago, in 2002, in which combination of immediate loading and early loading, immediate loading in native bone with two cantilever tooth on the lateral incisor position. That has been published, and all of a sudden, 6 months later, 4 individual crowns. Always remember that you got to have enough space in between the implants, otherwise 4 implants in the interior part of the mouth would be a nightmare for your dental technician, a nightmare for your patient from the biological point of view. And this is zirconia crown and ceramic crown and zirconia. And this is 12 years post-op. Are we placing implants when we have periodontal and endodontic lesion? Yes, we do. Like in these cases, as you can see here. Vertical root fracture, stenical root resorption, as you see here. Go very quick here. We are aiming to the incisal edge. We leave an intentional gap there. And we follow the Charno, Salama, Garber, and the other authors. I'm quoting only the one that I know very well. And so we are following the highlighted on your left or right-hand side. We place a graft in between our implants and the buccal plate. The only difference, we are not placing the graft in the soft tissue. We are placing a collagen sponge. We place only a collagen sponge, but Steve last night was telling me that he used now collagen, Bios collagen. We are using Endobono Bios. So when I'm at this stage, Fabio gets into the OR, he glues to a provisional seal in a little shell, and then he goes over to the lab, and while I'm finishing my surgical procedure, he does the 2 professional, and this is collagen sponge, and then we deliver the prosthesis. This is 1-week control, 2-week controls, 1-month control. 4 months later, we are in this situation, and Fabio does the prosthetic part. These are the types of abutment: straight abutments. We are not using anymore the, what we call the old shape of abutment. These are straight abutments, as you can see here. They are not very elegant on X-rays, but from our point of view, from the data that we are collecting, the soft tissue, you give me more room for the soft tissue. Immediate loading, and then Fabio starts working on the different profiles, and this is final zirconia crowns 2 years later. And this is happy patient. Another case in which we have soft tissue discoloration and fistula, more or less the same case, but for the soft tissue discoloration. Over there, we have bone at the collar, as you've seen near the tooth. We have the essence at the middle of the root. Same concept as you saw there. Pre-op, 6 months, post-op, final prosthesis, and the final prosthesis. We place the implants, and we think that there is a correlation between the position of the implants and the shape of the abutment. We saw a paper from Ernesto Lee and Joe Fiorellini. They call lingualized flap implant placement, but if you scan, these are scanned from their paper, it's just our position. They are aiming to the incisal edge, and with the shape of the abutment that they're showing you, the incisal edge, according to our parameters, is the best one. Not all the cases are going right in the right position. This is a case referred to us by a good friend of ours. He had a problem with immediate loading. He lost some of the tissue there, hard tissue and soft tissue. And he asked me to do something from the surgical point of view. At this point of my career, I'm not doing anything. I send everything to Fabio, and he does a modification of the abutment, modification of the prosthesis, and the day of prep, 4 weeks later, 8 weeks later, and the final crown. Obviously, there are some issues with the final crown, but remember when he started, and the patient is more than happy. So we think that with the concept of Omli Wang that he called the aesthetic triad, we are adding the margin geometry. So we shift from there to shoulderless abutment, straight, it's a different kind of abutment that plays a role on the soft tissue response. Another case sent to us to do some kind of surgical modification because it could not get rid of this cleft. As you can see here, Fabio what did, same abutment, modification of the abutment, modification of the provisional. This is the modification of the provisional. And this is the tissue response. Pre-op, new abutment, 2 weeks. New abutment, 2 weeks. There are some issues, yes, some issues, but always remember the starting point, and not very elegant X-rays. So conclusions. There is a learning curve embedded in it. You can shift and select patients. And if you stick to the literature, it seems that there is no convincing evidence that a clinically important difference in between the two procedures, the two loading modes. And I had the pleasure to be in the authors with Karmish and many others, as you see here, during another meeting organized by Henry Salama and Maurice Salama, and we wrote the workshop guidelines on immediate loading in implant dentistry. And these are the guidelines that are still following. And these guidelines were given to you throughout the lecture. But I think bottom line, only one diagnosis, different treatment plans, different ways to do this, the chosen treatment plans. And bottom line, there is an embedded learning curve, and you can decide with your patient if you get to immediate load or live the traditional way, early loaded, delayed loaded, that we know works very good. If you do immediate loading, you are more efficient, you can reduce the cost, reduce the fees, because you see the patient in the chair less time, so that you decrease the number of visits. Thank you so much for your kind attention. I really appreciate being here with you and sharing with